Hello and welcome to Race and Health Matters, a podcast produced by the NHS Race and Health Observatory. I'm your host, Dr. Guddi Singh. In this episode, we discuss what effective allyship looks like at the top of NHS organisations, how governance can enable or inhibit progress, and why board-level scrutiny matters for change on the ground. Welcome to you both to Race and Health Matters. It's a real pleasure to have you, not only because you're looking very, very nice on that side with the other. You're looking the part because today we're talking about what's going on behind the boardroom. And what I want to investigate is the role that non-executive directors can play in shaping workforce race equity in the NHS. So that's what we're about to talk about. I'm so delighted to be joined by Sim Scavazza, who is the Deputy Chair of Imperial College Healthcare NHS Trust, and Ras.I Martin, who brings a younger, more public-facing perspective on race, inequality and accountability in public institutions. So I'm going to start actually with you, Sim, if that's okay. And for people who may hear non-executive director and think about someone who's actually quite distanced as opposed to someone who actually has influence, can you give us a little bit of context about why boards matter so much when it comes to workforce race equity?
It's really important that people are held to account for their actions and for the way they think about things and the way that they frame things. So boards are important because they add value from an overseeing point of view, from a guidance point of view, from a check and challenge point of view. So it's really important, whatever the matters are, whether it's quality, whether it's EDI and diversity, it's really important to have that external influence. And most non-exec directors have worked at other places. You know, they bring a lot of wisdom and different sorts of judgment, and they don't carry the legacy or the weight of the institution in the same way the executive do. So it's easier to see things sometimes more clearly, and it's easier to see the effect of things, I think. So non-exec directors are very, very important, and I think it's become quite a sort of an onerous job actually in the NHS. So yeah.
And I guess the question to both of you really is, why should anyone listening to this think of the workforce race equity issue as something for boards as opposed to HR? Like why? Because we think of it as an HR issue, don't we? Right? But actually, we're saying something different here. We're saying that actually the board should have this front of mind.
Yeah.
So why is that?
Yeah, I don't know. It's really interesting. I think it's for two kind of key reasons. One, I think leadership across the board is super, super important, right, on this topic. This isn't kind of an aside, right? This is actually very much front and centre. And I think the other dimension is the fact that we're dealing with patients, right? This isn't a kind of for-profit business thinking about healthcare. And so at the end of the day, everything has to be in service of the patient. And so it isn't just about the staff need to be empowered. It isn't just about the customer, in this case, the patient, needs to feel a sense of connection with a brand or something like this. It's more than that, right? It's the actual outcomes. And in a lot of senses, right, it's life and death. Yeah. It's real impact. And so I think that's why you need this holistic approach rather than just saying this is an HR matter, which it is. But in addition to, it's also everyone else's concern, right? Really very much, top down. Every single person should be thinking about this issue. And so that's why I don't think we can just put it in that box.
Absolutely right. Absolutely right. And a lot of times the question of DE&I is outsourced to HR, as if HR are going to change the world. And of course, what HR do is implement policies. They come up with policies, they implement them, they help maintain consistency and clarity and stop variation. But actually, as you say, it's everybody's business. And in fact, my experience is if you don't have an engaged CEO and board, nothing changes because the institution knows that actually we talk about it, we fill the boxes, but it doesn't actually matter when it comes to patient safety and that sort of thing. But, if you look at the correlation of the best performing trusts at the moment, it's heavily linked to how those staff feel and how they're treated and how ethnic minority staff are treated within those cohorts and what the culture is like. And that is set by the board and then by the executive.
Yeah, I think you're right that there is inevitably cultures are set from the top down to some degree, right? It's all about, that's what leadership is about, right?
Correct.
You're setting the tone. And, I've worked in many different NHS institutions, and sometimes, my concern has always been that this idea of scrutiny from the board, it almost feels like it's more like it's procedural as opposed to actually genuinely searching for, the truth and wanting to kind of surface the difficult to raise things. And what you're saying is actually that unless you get that kind of cohesive leadership and vision right from the top all the way down, you're not going to get those high-performing trusts. And obviously all these things are very, very linked. And at the end of the day, it is about patient safety, right? It's about good outcomes for people. Again, like when we talk about boards, and I'll say this as an ordinary clinician, it seems like it's a mile away from my day-to-day reality. But if you were to explain to me, why does governance matter in this way? Because I think we need to just understand why this is a very important mechanism that we have open to us in terms of thinking about equity. Why does governance, or why should governance matter to someone like me when I'm not even around the table?
It's all about accountability, and it's all about getting to be the best and wanting to be the best and utilising all resources to be able to maintain a position, to improve and progress. And for that, you need scrutiny. You need people that have other experience from private practice or from other places that can bring to bear their experience and really help the exec become the best that they can be. Because at the end of the day, people like you report into divisional directors report into the executive, and the executive needs to be held account. And it's a wonderful relationship because it's checks and balances. Sometimes it's tough because, why are you doing this? The results aren't good enough. But sometimes it's what can we do to help you? What can we do? And to bring a different perspective sometimes is really useful for the executive, really useful, because they're deep down in the detail, and I can bring to bear my experience from retail, where we're used to dealing with customers and perhaps patients aren't thought of as customers, but actually there's a sense that they need to be in order for us to change a service delivery model. So actually it can be helpful and it can be useful. And of course the NHS is heavily regulated. So there needs to be absolute, that's why it feels a little bit performative sometimes, because we've got to capture a lot of evidence and a lot of data, right?
Yes.
But it's not all about that. Neds are human beings. We visit the wards, we speak to our clinicians, we value the people we know, because that's the greatest asset that we have in order to deliver what we need to do to patients.
And I think what's striking about both of you actually is that you have this other experience, that you're not so kind of indoctrinated in NHS speak or, philosophy almost, that you can actually just challenge it or look at things critically. And Ras.I, from, I guess, a younger staff perspective or just even future leaders, what is it that we need to understand about boards in terms of responsibility and the kinds of responsibility that we can all have in that sphere?
There's so much to unpack there. I think from the young person's perspective, I think there's a need to recognise, and I think for boards and to think about, right, at the fundamental level is thinking about strategy, thinking about leadership, and where is the hospital going? How does it cope with the challenges of tomorrow as well as the realities of today? And I think for more and more young people, I think that's the sense of what we're thinking about, is that across the board, things are looking incredibly different, and that's going to have massive effects on healthcare. It's going to have a massive effect for clinicians in healthcare delivery. If we think about the implementation of AI as an additional tool for clinicians, right, that will change the face of work, and that's going to be most felt by the youngest clinicians because they're going to be dealing with that piece of technology for the longest amount of time. And so I think there's a need to recognise both the kind of community health challenges as well as the clinical realities and how they're changing over time. And I think that's that adaptability piece, which I think is so important, to think about what is going on and to really be open to the voices, concerns and thoughts of the next generations coming in.
And the reason I ask that question is because so many clinicians like me have thought of themselves as divorced from that process of governing the institution that they work for, almost as if it's a completely separate world, right? And yet we all have a role in governing, even if we're not around that table. And I'm curious about that process of how someone like me can feed up into that process of change at that board level, because it's a two-way process, right? We talked about culture being a top-down process, but really there is a ground-up element to this. And I'm very much into that idea of things from the ground up and from the grassroots. And so I would like us to think about that in terms of the role of non-executive directors and how they can channel some of that word from the ground almost. Can you, Sim, kind of speak to some of the kinds of maybe great examples you've seen of influence that non-execs have been able to channel in that way, whether it's been from taking things from the community or whether it's just been from themselves. What's a good example of what this could look like so that we can picture it?
I suppose the thing that springs to mind immediately is conversations, communication with. Because if you sit in an ivory tower and pontificate, and sit in a board meeting, but you don't listen to the staff or go out to the wards or visit and give a sense of who you are so that the teams, you can say, oh, so that's what a non-exec looks like.
Yes,
that's the sort of question they ask. One that is right left of field. It's not so operational. It's about how people are feeling and why things are happening, the understanding. So it's the connection with. So it's really important, I think, that board members are visible. And they can lead by example. So the sorts of questions that non-exec directors ask are different. They're framed differently. I would call them professional question askers, right? So the way they frame the questions, what they're getting at to help lead and guide the thinking is useful for the executives because it opens it up. And it's a logical sort of sense of thinking. It's deep. And it's the thing with non-exec directors, we understand that things have to be joined up. And they're not. And the reason perhaps you feel divorced is because that's not your training and that's not your frame of reference. But going forward, if we're to tackle some of what you said, young people will absolutely expect that things are joined up. That these silos don't exist anymore. That it's seamless. And of course, if you start building a service from the patient first, I'm afraid the NHS wouldn't look like it does today. It would be completely different. Like a retailer, you build from your customer. What do they want? And you work backwards. Not, oh, look, we've got this service and we're going to tell you to do that. Doesn't suit the individual. Right, we've got a lot to join up.
You're
but
so
it's
right.
starting, isn't it? Think about it. We talked about groups. We talked about clusters of hospitals sort of coming together. So the left shift will help this as well. But this coming together is in people, is in services, is in estate, is everywhere and everything.
It's interesting because you bring up the left shift, which is this move towards like neighbourhood care and like healthcare in the communities. But I love what you're saying here, which is that actually, if we started from the premise that the patient really was at the centre of all of this, everything has to be redesigned. Because you're right, like health systems are currently designed, I'm not sure with who in mind, because I don't think it really works for clinicians either. I'm not sure they work for clinicians either, to be honest. Like from my perspective, I am very frustrated with the way that health systems work. So it's almost like it works for its own like logic, like its own like the old 20th century factory model of healthcare, right? Which is that you process patients and you chuck them out at the other end. Whereas I'm much more interested in relationships and developing like a continuity of care across these different fields. And what you're saying and what I'm hearing from you is that actually non-executive directors can be pivotal in trying to help shift that mindset of the institution in that direction. And, again, Ras.I, coming from outside of that traditional executive pathway, that's a helpful thing, actually, isn't it? That fresh perspective. Like, for you, what does effective board influence look like?
Yeah, so the point that I wanted to make was around the importance of kind of outside influence, right? And you mentioned a point earlier around the kind of socialization of the NHS. And I think that is a massive, massive, massive factor, right? We kind of become a product of our thinking. And I think a part of the work culture of the NHS is also long-term kind of service, right? Which is a beautiful thing. It's a beautiful thing that people want to stay within the NHS and there is opportunities for career growth and community and all of these things. That's beautiful. But as a byproduct of that kind of can come, not necessarily, but can come groupthink. And I think that's where the outside perspective is so important, right? From that intergenerational piece that you've kind of just mentioned, but also professional as well. And so that accountability side of things, I think is really asking, not just the challenging questions, but also the simple questions. And I think that's what good accountability looks like, right? Often we kind of can have a conversation about a topic and we have some premises underlying that conversation, but we don't really call them out. And so being able to ask simple questions from a non-clinical background to people who are dealing with these problems every single day, and all of a sudden a string unravels, which actually shows that a piece of thinking has been marked in something else, when it shouldn't be. And it goes back to your point, right, about how would we actually design this system, right? It doesn't fit well for clinicians, doesn't always fit well for patients or doesn't fit well for patients. And so actually challenging that idea. And I think mixed with that, the real difficulty is the NHS in two factors, right? Its size, it's massive. Right? One hospital, you're dealing with, tens of thousands of employees. And for any business, that would be an incredibly hard challenge. But then you combine that with legacy systems, right? On an actual, the kind of procedures, the technical side of things, the digital side of things. And you mix that with the budget constraints as well. That is a recipe for serious, serious challenges.
Yes.
And so I think this is exactly why you need outside perspectives, questioning things and thinking of what's to come next, not just dealing with the problems of today. And I think as you were saying, right, like that outside perspective when you aren't, in the weeds of it, thinking about, I'm dealing with this particular crisis, which is happening on X ward right now. Actually, I'm not thinking about that. If it came to my attention, I would be, but I'm not close enough to the detail for that to be occupying the majority of my thoughts. So I'm thinking about, the hospital overall, how pieces come together, and then the bigger picture with NHS England, right?
Yeah, I mean, you're right to talk about the size of the NHS. I think the NHS is still the largest employer in Europe, which is staggering when you think about it, right? And so no wonder it's a really hard behemoth to try and shift in terms of its direction and what it's doing. There's a systems expert called Don Berwick who has long reminded us that culture is shaped by what leaders and overseers are curious about, what they're alarmed by, and what they're willing to revisit. And it strikes me that actually that's maybe what the role of non-executive directors is to introduce that curiosity, because it's genuine, because you're coming from the outside, that you are willing to be alarmed by these figures, the outcomes, the performance, and that you might help to keep people's attention on things that might be actually quite difficult for people to stomach. And I wondered whether, Sim, you could speak to this the non-executive director who's actually willing to stay with the discomfort.
Yes.
Of keeping a topic on table, even though everybody else would just wish you'd shut up.
Yes.
Can you speak to that?
Yes, it's really interesting because you can imagine from a non-exec's point of view, where we hear of these scandals in places outside of your own trust, the question I always ask is, how can you assure me that this will not happen here?
Yes.
Because from what I can see from the evidence and where the lessons learned have been sort of extracted, this is really scary. So that's when you sort of bring something back on the table, even if you've got a CQC rating of outstanding in your maternity unit, you've still got to ask that question because I think this business of the NHS is so precarious. I was talking to the CEO of Imperial and we were talking about infection prevention control and, you're one step away from one nurse or one, consultant not washing their hands for the whole IPC, sort of chart to start ringing red and there'd be big problems. So it's incredible the amount of risk that the NHS and everyone working in the NHS deals with every day.
Yes.
So you've got to keep the questions going.
Yes,
And you've got to be brave enough as a non-exec to be able to do it.
Exactly.
Right?
Okay.
It's asking the question that everyone's thinking, that no one sort of dares say, and always bringing back. So from the patient point of view, what does that mean then? Because the exec, it's so complex in the NHS, it's so overcomplicated that things get lost in the why as opposed to the who. So we can come in and say, yes, but what's the impact actually of all of this work on the actual patient? Because if there isn't any, stop doing it. The lists just seem to grow in the NHS. They don't reduce.
Yes.
So the stopping of things is quite difficult. So there's an enmeshment. It's what I see as an enmeshment. It's very difficult to be creative in the NHS when it comes to process and procedure. So heavily regulated, really difficult for the executive. It's up to the non-execs to be able to lift them up into the sky, out of the weeds, as you say, to look for hope and to look for change, because creating change in the NHS is deathly. It's really hard, really hard.
Yeah.
And we all have to pull together. This is why NEDs need to think system. We can think system, we can start moving left. If we don't, we're all stuck.
So you've both said in different ways this thing about having the courage to speak up and to kind of hold boards to account. we've kind of, I feel like we're skirting around the issue, but I'm going to just take a head on if that's okay with you. As people of colour in that position and on the issue of race equity, can you just help me to understand how that works? What is it? What has your experience been like? And what would you say to other potential people of colour who might want to take a NED position? Because how do we harness this power? I'm very curious about this.
Yeah.
Raza?
That's a great point.
It's where to start.
Yeah.
I mean,
Yeah.
where in the goodness me are we going to start?
Yeah.
Yes.
I think, to be transparent, it's hard.
Of
Like,
course.
it really
Of
is,
course,
right?
yeah.
You know, and I think this is something which is really challenging, right? In an institution which, despite having a workforce which is massively represented by the global majority,
Yes.
At its leadership, it really isn't, right?
Right.
And
Still.
it's the same,
Yes.
right? And it's the
It's
same.
getting worse.
It's getting worse.
Yeah. So if you look at the res data,
Yes.
the workforce race equality data, you know, at that executive
Yes,
level,
yeah.
and the board sort of level fluctuates
Yes.
because board members, you know, have 3-year terms, so it's sort of up and down. But it's not good. It's glacial in its movement.
Wow, that's-
so one has to ask why. And my understanding, and from what we can see from the figures, is the pipeline isn't there, so people aren't given the same. People like us, or people, you know, with different ethnicity, or, you know, different ways of thinking,
Yes.
because protected characteristics
Yes.
are not just about race.
Of course,
here.
yes.
You know, if we can sort out race, we bring every other protected characteristic with us, but there aren't the same opportunities, which means there isn't the pipeline, which means there isn't the management development, so that people are ready when something comes up.
Yes.
So what we're doing at our group, the
Yes.
North West London group, is we are looking at what we're calling talent management. So not succession planning, not who's going to step into that, but who are the stars, the rising stars in our ranks across our 4 hospitals in North West London? What do we need to do to be able to bring them up, to get them ready to step up and step in when the time comes? And it needs active management.
Yes.
You've got to spot them, you've got to nurture them, you've got to put them on training courses, you've got to give them mentors.
Yes.
And then that's when you start seeing the raising up, if you
Yes,
like, the
yes.
nurturing. And you're deliberate. Right.
Well, that's what I'm hearing.
You're
You're being very
deliberate-
intentional about this.
Intentional. So we will have there will be people that will be look at these rising stars. Let's ask them, what do they want? Are you ambitious? And then, so it's about growing your own.
Yes.
You know, it's what private companies do.
Yes,
It
yes.
costs a lot of money to go outside to bring people in. You want to grow your own.
And there's a huge amount of talent, right, within the
100%,
walls of
100%.
where we exist.
Yeah.
100%. And I was going to say, like, on the topic of, like, directly head-on addressing issues
Yes.
of equity and of race at governor, at board level, I think one of the biggest challenges, and I think this is NHS wide from all of the kind of adjacent conversations I've had, which is the thinking is that that dealing with equity, dealing with equality is a second order condition. And what do I mean by that, right? Like, it is something to deal with when we have our other things sorted. We need to
Yes.
deal with the wait list. And, you know, this is verbatim happened in some conversations I've had,
yes.
right? We need to deal with the wait list first, and then we can get to this. Despite when hospitals' populations of patients and of staff are still majority in some cases, right? In a lot of trusts in London, right? Are majority, global majority, right? And still with that context, it's seen as, well, we'll deal with equity when it comes to later.
Yes.
And I think there's a need for a shift, and it's slowly happening. You know, and I've seen it over the 3 years I've been a governor, right? Slow shifts over repeated conversations. And this is exactly the point that we were discussing earlier, right? When you hold something, even when it's challenging, even when people move on, holding something and bringing it back to this point. And for me, at my hospital, I've seen that slow shift of slowly people understanding that actually this is a care quality issue,
Yes.
as well as a moral issue, right? We should care about, people's issues, but there is a care quality issue as well.
cultural issue.
100%.
And a bad culture in an NHS trust
Yeah.
means poor patient care.
Care.
There's
Yes.
a direct correlation.
Yes.
Yes, we've seen it
Not
time
a
and again.
separate project
Yes.
where culture is toxic. There are quality and safety issues. We've seen it in the maternity scandal.
Yes,
so
yes.
there's no avoiding it. And it's not a separate issue. And the trust that create an environment where ethnicity and difference is part of the everyday conversation is where it's working. So I always used to say, when I was doing some work for NHS providers, that when I can get the chair of the audit and finance committee to talk about ethnicity and diversity and all of those and equity, that is the acid test of things being moving on. Because what we don't want to have to do all the time is bring up the ethnic question.
Well, exactly.
And for us people to look at us, all the white people in the room, to go,
oh,
here
are
we
you
go
going
again.
to answer the question? So I sit back. So on interview panels, there's always the EDI question of the, and I say, I'm not asking that question, am I?
Yes.
And so everyone, no, that's quite right. Because I'm the token black person to ask the token question about ethnicity.
Exactly.
It's pathetic. So it's about people. It's everybody's responsibility.
Yes.
It's everybody's responsibility. At Imperial, we've got nearly 16,000 people, of nearly 70% of which are, from an ethnic minority or part of the global majority. So, what are you talking about? So every conversation we have is either about staff equity or patient equity, because you can't talk about a patient, a waiting list, without talking about equity.
So refreshing to hear you guys say that, because for me, I feel like I've often, even in my own on the ground improvement work, I've had to make the case for looking at equity as opposed to efficiency. Well, we're very good at efficiency, aren't we? We're always about doing things faster, quicker, making lists shorter. But bring in equity, and you're right, it's almost treated like it's a luxury, an afterthought later. And I agree with you. You can't get excellence without equity.
Correct.
Right?
Efficiency is gaining equity. That's the point. It's not a separate issue.
Yes.
It's reframing and helping the NHS understand it's not a topic. It's part of the fabric of the way you think, how you deal with people in a decent way. It's cultural competence.
Yes.
It's taking the time to understand others. And perhaps you have to do some work. I'm really sorry. You have to educate yourself, don't you? We expect that of people that come to the NHS, and people that don't do that shouldn't be in the NHS.
I think also it goes back to the conversation we were having earlier as well, about the system of the NHS, right? And is it, I guess, fit for purpose for today's needs?
Yes.
And thinking, the reality of specifically thinking about race and ethnicity and healthcare is that deprivation is linked with ethnicity, right? That there's a disproportionate amount of people living in poverty, living in unstable housing, who are people of the global majority, right? And so when we think about deterioration, when we think about DNAs, when we think about patients needing to come into hospital, there is a need not just to deal with the reality of understanding that these people are coming in more and the reasons behind that, but it's also thinking about that wider systems connections, thinking about social care, dealing with financial issues, dealing with education issues, all of these different things which interlink and result in someone needing care in the first place.
Yes.
And so we're talking about this left shift of a need to go from prevention rather than to cure, and I'm 100% in support of that. But again, what has to be a crucial, and again, not a second order condition, is thinking about how does ethnicity, how does equity wrap into that piece? How do we really understand the factors which are pushing people to come to the hospital?
Yes.
And when they come here, how do we make sure we deal with them in
Yes.
the most equitable way possible?
It's the population data that will give us that. So we can see where and the local authorities are very good at this. They know exactly by postcode, by road, where that deprivation lives, where it is, because they have to support it all the time. So we work very closely with them at ICB level, and that's where you start getting the waiting list down. That's where you start operating out in the community, because it's wrapped up. If we tackle the equity bit, we tackle the depravity bit, the deprivation, and then we tackle our the admittance to hospital. It's the way people look after themselves, and we need to reach those that aren't able to do that.
100%. It's all about those social determinants of health and acting early rather than late. What's interesting to me is that you're bang on that there is data that we can use to help sharpen our focus. But we've had years of res data,
100%.
Right? We've had years of the workforce indicators. And I'm sorry,
No.
I'm not trying to be cynical,
No,
actually.
no.
I guess the question is, we've got the data. Actually, the data exists. Yeah. And the question is not about whether, we don't know what's going on. Yes. The question is, how do we hold boards accountable to the data? And so let's be tangible now. So for anyone who's listening and who might be interested in doing a NED role or is in a NED role, how would you guide them in terms of the kinds of questions that they can ask at that board level to keep that accountability? And you mentioned it before, you have to keep bringing people back, but what kinds of questions are good, powerful questions on that?
Can I, before we even get to questions,
Yes.
right, I think it's important to think
Yes,
about
yeah.
why haven't we acted?
Okay.
Or why haven't things changed?
100%,
Yes,
100%,
yes.
right? I think there's a report done in 2009, right, which again showed the impacts of racism on health outcomes.
Yes.
And so we're thinking about decades of very much acutely understanding there is a link between these two things. And if we truly put the patient first, if we're truly thinking about improving patient outcomes, decreasing costs as well, because if we hit these issues head on, we decrease those things across all the board, right? This hits everything. Why haven't we dealt with it? I think at the core, we need to be really transparent. It is a lack of care.
Yes.
It is this issue not being seen as something worthwhile and seeing it as something which is important, but we hand it off elsewhere. And that's harsh, but I think it's important to be honest, right? I love the NHS, and like you would love a family member, you tell them honestly what's going on.
It's like the uncle at Christmas who's
Do you know what I mean? Like this is
being a bit bigoted, and you still love them, but like you need to hold them to account.
Exactly.
Yes, yeah.
And so starting with that, right? Like that change happens in a large organization, it has to come top down. And so if the top doesn't fully care in the most meaningful sense of that word, where equity isn't embedded into every single part of the process, change doesn't happen. And I think that's what we're seeing, not just in one trust, but across the NHS.
Yes.
And so I think the second part then, what are the questions, I think is, and again, this is the family analogy. I think you don't, it isn't through shouting or whatever, which even though that might feel just, it is trying to change hearts and minds, for lack of a better phrase, and really helping to educate and allow someone to understand that this is important, not because it's nice to have a photo op for Black History Month, but in reality that this is again about patient quality. This is about patient outcomes, and we care about this in every single way. So we have to care about it in this way also.
Yes, I love that. It's about caring and returning care to this. So how do we nudge people towards that direction of care?
The issue is that this is down to individualism, because actually it takes every single person working in the trust to understand where they carry their biases.
Yes.
I remember I did Samaritan training, and it was very clear that we all have biases, and it was very important for anyone in the Samaritans to be able to say, I have an issue with this particular topic, so I'm not going to be able to take that phone call. And you declare that, and then your members of the team that are on duty with you will take that call, right? So the education bit is a bit of self-reflection. Who am I? What have I been brought up with? What do I understand? What don't I know?
Yes.
What's the right way to speak to someone? What if someone's, upsetting me, but then I think about, their race or so. Is that right? How do I tackle this? How do I separate being cross with someone versus being racist? Am I racist? All these sorts of things, because there are lots of good white people who don't even know they're racist.
Yes.
And that's a big issue we have. So, but it takes the individual to go, actually, through training, through talking, through reading, through watching films, whatever it is, to be actually to take accountability of themselves. You can't outsource this. It's an individual matter, and then we all come together. So active bystander training, calling out things that are absolutely inappropriate. Not right to be said. So we need people to be able to feel brave enough to do that.
Yes.
You need to create a culture that's safe, so people feel they can call out something, which is really important, because actions speak louder than words.
Yes.
So and that's quite shocking then, especially if a white colleague will call out something. Another white colleague has spoken inappropriately to someone.
It's so powerful, right? When it happens.
It's shocking.
Yes.
And you're sort of, and it's a bit like smoking. Do you remember when people used to smoke everywhere? Now, if somebody smoked inside, everyone would go, this is ridiculous. We need that happening from a discrimination point of view. We need to say, no, this is not, this doesn't happen.
Yes.
This is not right. This is a long time ago. But we need enough of those people to come forward and feel safe, to be able to feel comfortable and confident to say that. So many people want to say something, they don't know what to say.
Right. Yes.
They don't know what to say, they don't know how to tackle it. They go, should just said something, but I don't know what to say. That's why active bystander training is so brilliant.
Yeah.
Helping a woman on a tube,
Yes.
being harassed, helping someone that's being verbally abused. You know, it's really important, and there are ways and stages and escalation. You know, so there's methods.
Yeah, there are
where you're
methods.
not going to put yourself in danger, but you can do the right thing and walk away and say, I did something.
Yes, yeah, brilliant.
Yeah, no, I think as well, like just off of the education thing, just looping back around, just thinking about just the grace as well in responding, right? As someone is learning, someone is understanding. And I think the challenge is that you know, people sometimes are worried about, you know, their lack of understanding, and so try to be, you know, and can actively be defensive when called out and all of these things. And so again, there's this call out and call in, and there's two opportunities for both of them, right? When it's happening, it's 100% it's a call out. It's protecting the person who's been affected by the discrimination or whatever it is, right? Micro or macro. And then the other side is the education side, calling someone in, helping them to understand and allowing them a space to ask questions, get things wrong, and you know, be with them through that journey. That it isn't just about discounting someone, saying, actually, you know, you're gone forever. But actually, as this wider NHS family, is that we can come back together, but come back stronger.
Do you know, as you were speaking, I was remembering, so my daughters have got your hair, but much more curly. And for some reason, people feel that they can just go and touch it.
Without even
and
asking.
they don't realise that it's completely inappropriate.
Yes,
you wouldn't go around touching people you don't know. These are strange people.
Wow.
Strangers.
Yes.
So it's those little things that people just take for granted, that it's about education.
100%,
And you call it in to say, actually, you're invading my personal space.
I mean,
That's not
it's
what
a silly example, and yet it's a really profound example, isn't it?
It's profound because it's so personal.
Absolutely, yeah.
And one that people think, shrug off and go, I was only just wanting to feel what it's like. It is the, you know,
Yes.
People don't see it because they're not used to it. If you've grown up white in this country, you're not used to these sorts of things. You're the majority. You see yourself, you know. But we're in London. Look at where we are. You know, this is a microcosm, and the NHS is a microcosm, isn't it, of the nation, right?
And I think we forget that at the end of the day, the NHS reflects our broader society, right?
Correct.
And it's not just like it's the NHS culture in isolation.
At what the broader society at this moment in this country is going through, right? So it's really important, as I think you said, Ras, it's just sort of, it's not hectoring. It's bringing people in. It's helping them if they get it wrong. It's being graceful about people making mistakes. We all make mistakes. How many parents are making mistakes with gender at the moment? And what's called what and who's
Yeah, absolutely.
You know, what do you do? Shout at them? No, you sit them down and say, "Look, Mum, look, Dad, this is the way." And that's what young people got to put up with.
Yes.
But you know,
I was also going to add something, right, to the hair actually example. It made me think was, again, from personal experience with that exact same issue. But I think what's so important is, and you mentioned this earlier about not being the token person in the situation. I think sometimes there is a natural, comfort to defer to the person of colour in the room, right?
Yes.
Like it's your job to both suffer through it and then educate as well.
Yes, it's that double,
and it
double bind, isn't it? Like,
100%. And I think this is where, you know, white allyship is so important, because it is using your, you know, effective protection from the lack of experience of racism to be able to tackle racism, and have to be the one to have those awkward conversations and hit it head on, right? It shouldn't be for us to deal with this. It should be for our white counterparts to really spearhead this. In the same way, allyship for me when it comes to feminism or LGBTQ issues, you know, that's my time to stand up and to fight against discrimination and to help re-educate people as well. It shouldn't be those with that lived experience that have to then also go out and be the force to break that.
It's true, because I chair something called the CCOL group, and that's all the sort of global majority NEDs across all of our trusts. You know, we get together and we support each other, and we try to create pipeline for boards and that sort of thing. And some of them are exhausted. You know, some of us are exhausted, tired.
Yes, I'm sure.
It's constant. You know, it's tired. But and we do this because of the generations coming after us. You know, if not us, who? But it is exhausting.
Well, I mean, I think this is the thing we underestimate, right? Whether it's allyship in that sense of literally, you know, the other, or if it's you're doing it for your own people of your colour or whatever, it costs, right? It costs
Yeah.
time. It costs, obviously, affective labor, your emotions, but also your credibility is on the line. Yes, and the comfort that you
Yes.
have is always
100%.
going to be at risk there. And I guess my question is, how do we again generate cultures in which you are supported to do that? Because we need that. We need that is the brave, courageous thing to do. It is the right thing to do. You don't need to convince me, but the question is, how do we make sure that we can support people like you to keep doing the right thing? As you said, it's tiring.
Yeah.
I just want to just flesh out that point a little bit that you were making about this kind of fighting against it. And there's a great analogy which I heard about racism to help white people understand it, is that the effects of racism and the structures around it are as if it's an escalator moving one way, and it's one thing to stop walking down the escalator, right? And that's stopping being racist. But it's another thing, the discomfort and the sacrifice of walking against it. Because even if you do nothing, you're still moving with the flow. You're not changing the systems, and we're still affected by it.
That's a brilliant analogy.
So there's a need to recognize that it doesn't come from comfort. It is uncomfortable, even if you're white. There is still sacrifice around credibility, around your mental health.
But this is what I mean. Like, how do we even make it okay for white people to call this stuff out, right? Because you're right, it costs them too, right?
Yes, yeah.
Yeah, but there are good people working in the NHS.
Oh, yes, of course.
Emotionally strong, good people that are service driven, right? Are driven by helping others. And actually, if you tap into that pit of their psyche and explain the help that they can give other, it's a miracle to them. It's like, we can actually be useful. Yes, we need to unleash their kind of their power.
That's interesting.
Their daily kind of power to change things. All of us, each and every one of us, every day, have the power to make it better for somebody else.
That's interesting.
A kind word, a nod, a look in the street, whatever it is, it's so important and it's so simple.
Yes.
In such a complex, horrible world, it's the really simple things that actually make us feel good, right? And the person on the receiving end feel good.
Yeah, exactly.
Right?
It's a win-win,
so
isn't it?
perpetuate that. So if you're walking around the hospital and that's what's going on between the teams, between the patients, it's horrible, but there's a bit of sense of humour. There's life goes on. We're human beings. We're all in this together. It's that sense. And countering the anger and the angst and all of the things that happen.
Yes.
We need people to be strong leaders to come in and just calm, and it's okay, and it's difficult, and we get things wrong, but that's all right. That's where we learn, right?
It feels though like what you're saying is it's actually leadership at every level, because you're saying it's like you are a leader when you do that
100%.
on the ground, right?
If you're a line manager at band 5,
Yes, exactly.
That's where you have
and
to
you're
be.
the person who's like, giving the wink to someone to make
Correct.
them, lift up their spirits
and
that day.
lifting them up, lifting them up, understanding they've got human issues, but they still come to work, and we've still got to sort patient safety out, and they've still got to be abused by the patient and the thing, and they still have to do their job and deliver the care. So tough.
Yeah. I think I completely agree, and I think it's such a beautiful point. Like those everyday moments, there's an opportunity every day, as you said. Like it can be a smile, it can be all of these things, opportunities for leadership, and irrespective of your band as well. Like there are moments for leadership. Even leading. When there are people more senior than you, there's possibilities for that. Yeah. And I think the other side, though, and I think this is also linking into the Ned Governor's perspective, is I think the top down really does matter. I really do. Like I think it is so important. And you see it, what the chief exec demands and expects will be done. And again, if that's their approach of thinking about it, doing that self-reflection, the humility piece for themselves, and the education for themselves, it will happen for everyone else on the board. It will happen for everyone else under them, and that cascades down, right?
Yes.
And I think the thing is with the opposite way, which I think is still incredibly important, but there are ceilings to be hit. And even if we see it in the banding, right, leadership is predominantly white. And so we have this natural kind of system, which means that from the ground up will effectively be those being affected by it. But those wider systems for those who are not affected by those issues will remain the same. And so you need to have the top down so that we see the effect and the impact happening at every single level.
Yeah.
We need to break those systems.
Oh, 100%.
That's the thing.
Exactly.
We need to deconstruct them.
Yes.
They
Say
need
that
to
again?
be We need to deconstruct
We need
those
to break the
systems.
system. I
Correct.
love what you said there.
Yeah, we need to break
Yeah,
them.
that's
We need
amazing.
to snap them in half. And I think of the CEO at Imperial, actually, Tim. It's Professor Tim Orchard, and he's got something called a Dear Tim letter.
Okay.
So any manager who is interviewing or has an interview panel has to write a letter to Tim if the interview panel isn't diverse and if the shortlist isn't diverse, and then has to explain if they take on someone that isn't of this colour, why. The justification. So what we've seen is a gentle edging up of the selection of global majority people in band 7 and above. It's slow, but the minute you just say,
Yes.
like, tell me your reasoning,
Yes.
and write to the CEO.
Yes, yes.
Can you imagine? I have to
Yes.
write to the CEO to go, and you have to go through all the candidates, and you have to look at why, and you say, did I make that decision? Well, you reframe, you turn the thinking, you incentivize them not to have to write a letter
That's
to the
fantastic,
CEO,
isn't it?
and you don't just put it in and say, right, that's that for 6 weeks. That's it. It has to go. It's years.
Yes.
We need 2, 3, 4 years to get that.
Yeah.
To get that kind of,
Yeah.
trajectory. So, yeah, really
I
important.
love you both. I think you've got such amazing energy. We're going to have to wrap up soon. But on that note, actually, of these like sometimes tiny, practical, but really powerful interventions, what would you suggest that, one question or one kind of maneuver or one kind of approach that a Ned could take?
Yeah.
That, or maybe even better, what's the kind of question that should be asked regularly of a board? What should we never stop asking a board to do if we're going to take race equity seriously?
It's really difficult to put into one question.
Sure. Mm-hmm.
For me, it's about my pre-positioning of my colleagues. Boards are big.
Yes, say more about that. Yeah.
So what that means is expecting that we talk about equity at every board meeting,
Right,
in
okay.
every meeting, as I said, in the finance meeting, as well as the audit meeting, as well, everywhere. It becomes pervasive.
Yes, okay.
And in order for that to happen, I have to get the rest of the Neds to be comfortable to do that.
Yes.
So I don't have to they're bringing up, well, what about the EDI dashboard? And, it's not good enough.
Yes.
The executive is
Yes.
too white. When you get another white person saying that about the executive, it's like, my job is done.
Yeah. They're doing the work for you.
And you may continue, right? Arguing. Well, I haven't got any. One of our vice chair, I haven't got any ethnic minority Neds on my boat. It's not good enough. My job is done.
Yeah.
So that's how I do it. There isn't one question.
No,
There are
okay.
several questions constantly, everywhere.
Yes.
That's the way to put
Brilliant.
it.
Okay, great
Several
strategy.
questions constantly, everywhere.
How about you, Ras.I?
I agree.
And again, it doesn't have to be one question. Maybe it's an approach. Maybe it's something that you would like to leave people with.
I think to bounce off of what you said, and I completely agree, right? For it to be embedded everywhere, the question of why haven't we talked about equity for every meeting, for every presentation, every report? Why haven't we talked about equity? And in a meaningful sense, again, not just a light comment, a throwaway comment, but where it isn't talked about, to bring people's attention to that until it becomes so ubiquitous that it's, I don't have to be there, right? As you've just said, right? Like, I think that's how you do it. You repeat it until people realize that it's serious.
Amazing. Thank you so much, both of you, for your energy and your excellent ideas. It's been an absolute pleasure talking to you.
Thank
It's been a
you.
pleasure. Thank you.
Thank you.
Thanks.